All right. Can everybody hear me?
Yep.
All right. So
Yes.
I want to welcome everybody to our P2 virtual meeting. I'm really excited that everybody is able to join. I know that this isn't really what we expected to be doing today, but it's really exciting that we're able to get everybody together even remotely. I'm still learning how to put this all together on Zoom, but this is a look at our agenda. So just a couple minutes before we get started. Typically in our previous meetings, we'll start with our top 10 POCUS articles for 2019. Then we have 3 wonderful research updates. If we have time, we have a break. That's kind of my hope. And then we'll have updates from our executive board. And then a panel discussion on education and research in this unprecedented time. So we definitely want to make this somewhat interactive as much as we can remotely. And so during the presentation, we're going to be utilizing the chat box. So please send comments or questions. And once, I'm not sure about the raising the hand, but if you put a question in the chat box, we'll recognize and call on you and let you ask your question. But until then, if you can keep yourself muted so that we can keep things flowing. So like I said, this is where we all expected to be today. Look at those beautiful mountains in Denver. And unfortunately, this is where we are. We're all scattered across the globe. So just before we start, I wanted to get an idea of where everybody is joining us from. All right, so just take a minute just to answer. All right, I think most people are almost there. Oh wait, no, sorry, this was the wrong poll. Hold on a second. Well, but it looks like most people are joining us from the couch. This is the poll that I meant to put up. Let's see where is everybody? Oh wow, we have one in Australia. That's very exciting. So I think most of us are still here in North America. Wait, it's shifting. We still got 4 more people to answer. But there's a good, it's nice to see that we have spread out across the globe, just like this pandemic. Oh, sorry, you guys didn't see that, did you? All right. And then the last question that I have for the group is, just tell me who you are and what's your position. All right, so I think majority of us, hold on, we got a couple more people. I think people are just joining us or doing the polls, but I'm going to end the poll right now so we can keep moving. So I think most of us are PEM faculty, but it's nice to see we have some EM faculty here, POCUS and PEM fellows, and even some residents. All right, sorry, wait, I'm going to stop sharing now. And I'm actually going to introduce our first speakers, Dr. Julia Brandt and Dr. Paul Khalil. Julia is a general pediatrician at Children's Hospital in Colorado. She completed her POCUS fellowship at Denver Health and Colorado Children's Hospital in 2018. And she is going to be starting actually her PEM fellowship next fall. And Dr. Paul Khalil is currently a POCUS fellow at Denver Health and University of Colorado. And he is going to be joining the group at the University of Louisville and Norton Children's Hospital after he completes his fellowship. This is our hometown team, and we're so happy to have you present this morning. Do you guys want to start your screen share?
Yeah, sure. Let me start mine. Sorry, my dog decided she had to go out now. So can you guys see my screen? Oh, hold on. I don't think I've shared it yet. Give me 1 second. Disable. It says disabled screen share. I don't know that I can share mine. It looks like it says host disabled screen share.
Stephanie, you might need to allow her to screen share if you're the host.
I tried again.
Oh, there we go.
Okay.
All right, hopefully now you guys can see this. Everyone see this okay? So thanks so much for the introduction. I'm Julia Brandt. I didn't answer the poll because I'm a pediatrician currently, and I'm going to be a PEM fellow in a couple of months. I did my training backwards. And I get the pleasure of presenting this with Paul Khalil, who is the current POCUS fellow at Denver Health. I did my fellowship last year. And we've included all of these wonderful children who are sort of forced to be our POCUS models from all the different members of our faculty in POCUS here in Denver. And we get to talk to you about the top 10 2019 pediatric POCUS articles. And I get to do the first 5, which I'm very excited about. So the first paper is looking at the accuracy of POCUS by pediatric emergency medicine docs for the diagnosis of testicular torsion. So this is one that wanted to focus on the importance of acute scrotum as a diagnosis, and it happens quite often. And the goal is to evaluate how accurate PEM physicians could diagnose torsion via POCUS. So it was a chart review study. And to be included in the study, you had to have received a POCUS before you went to radiology for your ultrasound. And you were excluded from the study if you had any known trauma, any recent visit to the ED within the last 7 days for the same pain, you had incomplete documentation, or you had your POCUS performed after your radiology ultrasound. So out of all of the different patients reviewed, 120 fit criteria, with the primary outcome being diagnosing testicular torsion via POCUS, and the secondary outcome was the agreement and the final diagnosis between POCUS and the radiology ultrasound or surgical, and also as well as a time difference in read result. So the good news with this is the result, the happy people can show you, is that there were no misdiagnoses of torsions. There were 12 cases total out of the 120, and none of them were missed by the POCUS performed. And out of all of the different cases, the 120, there were a total of 36 missed cases, cases of disagreement between the POCUS and the final diagnosis, which ended up with a 70% agreement overall in the final diagnosis in the POCUS, but specifically for torsion, it was 100% sensitivity and a 99% specificity. So the limitation to the study was that the people who identified the torsion on POCUS were all all ultrasound trained in some way. So they had either been in the middle of their ultrasound fellowship or they had completed an ultrasound fellowship. Otherwise, it was a pretty good outcome. So we can say, conclusion from the study is that POCUS is accurate for the diagnosis of torsion, with the caveat here that it was probably a P2 member who did it, or someone who at least had done a POCUS fellowship. The second paper looks at lung ultrasound in infants with bronchiolitis in a pediatric ED. This was a prospective study done in Rome from January of 2017 to March of 2018. It looked at only children who were less than 12 months old, and they enrolled a total of 76 infants for this study. Initially, they were ranked with a bronchiolitis severity score clinically from Seattle Children's, which was based on different clinical presentations, including retractions and signs of distress and dyspnea and respiratory rate, et cetera. And they were graded based on A, B, C, or D, how severe their clinical findings were. Once that was done, they had a lung ultrasound performed, which was via the Coppetti method, and they divided the lung into 3 areas, as you can see on the slide here, and then each quadrant of that was scored based 0 to 2, also based on a standardized scoring system on the severity of findings on ultrasound. The higher the number, the more severe the findings. So the primary outcome of this study was to see if ultrasound could predict who among the infants with bronchiolitis would need respiratory support, and they found that there was significance statistically on ultrasound score for those needing respiratory support and those who did not, and as well as duration of time on oxygen. However, it did not determine, it could not predict if they needed low flow, high flow, or non-invasive positive pressure. There was no correlation between the ultrasound severity score and the clinical presentation of oxygen saturation in the initial arrival at the ED. The limitations of the study were that the only 2 operators who did all of the lung ultrasound were pediatricians who had greater than 5 years of chest ultrasound experience, and they only looked at infants who were less than 12 months, given there's no clinical consensus on age interval to define bronchiolitis. And then out of the 76 infants, only 7 had severe symptoms by the Seattle Children's Bronchiolitis score. And the thought is that if you included children who were older and had more severe illness, there would potentially be a change in statistical significance. This is one of the graphs from the paper that just shows the basics of echographic score on the y-axis. The higher it was, the more likely for respiratory support being needed. But again, it couldn't quantify the kind of respiratory support. So conclusion from this is the higher the ultrasound score, the more likely you would need respiratory support. The next paper was looking at the diagnostic performance of emergency medicine, specific performed POCUS for acute appendicitis. So previous reports had looked at POCUS for diagnosing acute appendicitis, but were not specific as to emergency medicine trained as the operators. This was a meta-analysis study, and to be included in the study, or to be included as a paper reviewed, you had to have patients enrolled who had right lower quadrant pain. You had to have your POCUS done by an emergency physician first. You had to make sure you confirmed your diagnosis of acute appendicitis via surgery or pathology, and enough information to calculate a pooled sensitivity and specificity. And so overall, they reviewed 17 articles that met criteria for about 2,385 patients. And then 7 of these were pediatric specific. So the primary outcome of this study was the diagnostic performance of the emergency medicine performed POCUS for acute appendicitis. And that is for all studies. And then the secondary outcome was looking specifically at pediatrics. So you can see the results here that for the adult studies, it had a sensitivity of 84% and specificity of 91%, and which was improved in the pediatric studies. It was 95% for both. So the thought is that POCUS and radiology ultrasound do not have statistically significant diagnostic performances, and it's even better in pediatrics. In general, the limitations to this study were that they had to have confirmed conclusive cases of acute appendicitis, so there was nothing that was considered equivocal or inconclusive. There was an overall small number of studies included, and that as much as we all like to think that ultrasound is all we need, it's the only thing they looked at, and no man is an ultrasound island, so they did not include any other imaging modalities to evaluate acute appendicitis. But we can say from this paper that POCUS is an excellent diagnostic tool and even better in kids, with the knowledge that they only looked at 7 studies that were PED specific. The fourth paper was the training of general practitioners in lung ultrasound for the diagnosis of pediatric pneumonia. This was done in Bangladesh. It was a prospective study, and the goal was not just to train their practitioners, but also to develop a training program of evaluating pneumonia on lung ultrasound. One of the benefits of the study was it was showing the ability to train physicians in a low resource setting, with the concern that pneumonia is often a leading cause of death in these areas and difficult to identify. And there's no standardized approach in training physicians to acquire images and interpret studies of lung ultrasounds for pneumonia. So to be included, the patients were assessed for clinical signs of pneumonia using a specific clinical scoring algorithm, and then those that met criteria had a lung ultrasound performed. And for the lung ultrasound, they also developed a standardized training program to be able to identify pneumonia based on echographic findings. So for the training program, which I thought was really interesting, was they did 7 days for all of their remote experts, who were the ones who ultimately made the decision if there was a positive pneumonia or not. They were all out of Johns Hopkins, they were physicians who had some sort of extensive training, either in interpreting or acquiring lung ultrasounds. And they had 7 days themselves to make sure the training was standardized. And then the physicians in Bangladesh, there were 17 of them. And they also had a training program that spanned several months. They had to perform 25 scans on their own. They had to review 25 scans of another study physician. And then once they had greater than or equal to 80% accuracy in image interpretation compared to the experts, they were considered signed off. And then once they were signed off, they would do dual reads. So every lung ultrasound that was performed had 2 physicians in Bangladesh reading it. And if there were any disagreements, those went to the remote experts. And so looking at the study and how effective it was, that after all the education, they evaluated the agreement between the study physicians and the remote experts over time, and that in general, there was a 91% agreement after the implementation of the training program. And defining or identifying pneumonia on lung ultrasound, there was an 88% sensitivity and a 92% specificity. So pretty good. The limitations to this study were that it did receive a large Gates grant to provide ultrasound equipment, so it was considered a very expensive study, but this would likely change with the implementation of the handheld ultrasounds that we have now, but difficult to replicate this exact study in a low resource setting given how much it cost. It had no patient-oriented outcomes, and as we know, it's difficult to distinguish viral versus bacterial pneumonia on lung ultrasound. So lung POCUS has a good validity and can be taught remotely is our take-home point. And the last paper that I'm going to review before Paul starts is the utility of the pediatric FAST and pediatric blunt abdominal trauma. So this was a systematic review as well as a meta-analysis that spanned 32 years. It was from January of 1986 to March of 2018, and it excluded studies that had any mixed peds or adult populations, any studies with poor data, which were retrospective, or any other concerns for sensitivity specificity, and identified a total of 8 prospective studies, which were pediatric only. So those patients, there were 2,135 patients who had a total of 289 intra-abdominal injuries, and they included all the patients who had a trauma activation or known blunt trauma, but excluded those that had known penetrating trauma or those who were hemodynamically unstable. So the operators for the FAST were either surgical residents, surgical attendings, or EM residents or EM attendings, shown here by the superheroes with the POCUS, or a mix of the two. There was no standardized training for any of the FAST performed. There was a variety of training options done in each paper. So some followed the ACIP emergency ultrasound section guidelines, some had their own training that they developed, and some didn't specify in the papers. But compared with previous reviews, this meta-analysis used a far more rigorous inclusion-exclusion criteria. So it only looked at prospective studies. It only looked at FAST that were performed by an emergency medicine or a surgery physician. And then some of the previous studies had FAST, which were retrospective, or they had scans performed by radiologists, which skewed some of the data. The primary outcome of this study was the presence or absence of intra-abdominal injury, with the gold standard comparison to CT or OR hospital course. So overall, looking at the FAST use for identifying intra-abdominal injury, there was a 35% sensitivity and a 96% specificity. So the sensitivity was lower than the previous paper by Holmes, which is about 55% for sensitivity. And the thought is it's because that paper included radiologists as POCUS operators and the study did not. And you can also see the likelihood ratios below. So this paper can conclude that, as we know, positive FAST means an intra-abdominal injury is likely and should proceed along the next steps of surgical evaluation, but a negative FAST cannot definitively rule out an intra-abdominal injury. And you need to have continued clinical evaluation. And that's what I got.
Hi, and I'm Paul Khalil. I'll be taking you through the next 5 articles. Let me share my screen.
And sorry, Sig, I didn't see your question when I was screen sharing, but I can address that afterwards.
Let me see.
You probably, Paul, just want to put it on just regular slideshow and not on presenter mode.
Okay.
Because you're doing a screen share.
Okay. Let me exit out of this. All right, is this better? All right, so I'm going to be starting with my first article is going to be POCUS on Diagnosing Intussusception, which is a study out of Kansas City. It is a retrospective study that reviewed PEM POCUS physicians that first completed a point of care ultrasound that was later confirmed by radiology. Radiology can confirm it by either doing their own ultrasound, they could review the POCUS imaging, or it could be confirmed by the air enema. The second thing that they were looking at in this study was that what causes of failed air enema were noted in this study. They were able to include 101 patients, 75 of whom had intussusception, and 72 of whom had it detected by PEM POCUS. The authors did note that the three failed intussusceptions were early on in their study. They found that they were 96% sensitive and 92% specific with regards to identifying intussusception. They found that reasons for failed air enema were 1, the patient's age under 6 months, or 2, if it was distal to the splenic flexure, which they defined as being on the left side of the abdomen. They noted that commonly attributed causes of failed air enemas, such as age greater than 36 months, presentation at greater than 24 hours, or if it was recurrent, were not statistically significant. Limitations to this study was that there was only 2 PEM POCUS physicians that were doing these studies, also that it was a retrospective study. In conclusions, the authors concluded that PEMs can accurately diagnose intussusception. The second study I'll be talking about is POCUS for umbilical line placement. And while we as PEMs generally aren't placing umbilical lines in the emergency room, as POCUS champions, we're often called to teach other departments how to use the ultrasound. In this study, they did a review of 8 articles, and they were able to, 8 articles. The reason that imaging is important is that about 50% of infants in the first week of life have malpositioned lines, and this can even be higher in infants that are extremely low birth weight. They noted that typically what you do first is you calculate how far to insert the catheter, and this can be either be done by the baby's weight or the distance between their shoulders and umbilicus. They were able to attribute that ultrasound was more statistically significant for finding the catheter. In one study that directly had ultrasound versus x-ray, they noted that sensitivity and specificity for ultrasound was in the 90s, whereas for x-ray, it was in the 60s. There was also one small randomized controls trial that showed that ultrasound was more rapid in placement and treatment by over an hour. Also in this study, they showed that they reduced the amount of x-rays. In the ultrasound side, they did 4 x-rays, whereas they did 2 in the ultrasound side. Limitations to this study were that there were several of these studies that were done by radiology and not point of care, as well as that several of these studies had low ends, specifically the randomized control trial. The authors concluded that evidence suggests that POCUS is superior to X-ray for umbilical line placement. The next study was credentialing for PEM POCUS attendings. In this study, they drew a group of POCUS leaders to get expert guidelines for credentialing of PEM attendings. In 2009 and 2016, ACEP had set aside a set of guidelines for general EM attendings. And in 2015, AAP had set a policy statement regarding POCUS. However, they did not have specific guidelines for training or credentialing. So this group in 2015 were 6 PEMs as well as 2 general EM POCUS leaders. They first set applications as basic advanced and then defined how to obtain training. It could either be via an education pathway such as a fellowship, or it could be as a practice pathway after one has already become an attending. Competency assessment after education was in a 2-fold method. They were it had to be numerical as well as real-time assessment. Once a physician is competent, they then are able to be credentialed at the hospital level, which allows them to document and bill. However, one still needs to have quality assurance by a POCUS champion to review these imagings. Here is the basic and advanced applications, as well as the numerical numbers for credentialing. As you can see, for diagnostic studies, it's about 25 per exam, and for procedural, it's about 5. Limitations to this study is that it was a group, was expert opinion, whereas not as research-based. The authors concluded that we now have guidelines for credentialing PEM attendings. The next two studies kind of go hand in hand, and they're both P2-based studies. The first is POCUS applications for PEM fellows, and this was a modified Delphi method, which is that you have 2 or more iterations of data collection. To be a POCUS leader, one had to have done greater than 1,000 scans and either be fellowship trained, taught for greater than 3 years, or to be a director of a program. You were able to identify 48 experts that took part in the first round of the data collection that identified 8 items to include in the study. In the second round, 37 of the 48 experts took part of this study and were able to include 3 more applications. The studies that were included are the following. The studies that were excluded are here on this chart. And the studies that there was no consensus are on this chart. Limitations to this study is that was one, gathering all the PEM POCUS experts outside of P2, as well as general EM physicians were not included in this study. In conclusion, core POCUS content for PEM fellowship is now defined. The final study in our top 10 is POCUS applications for PEM POCUS fellows. This was also done in a modified Delphi method. Experts were to have greater than 1,500 scans, plus one of the following: demonstration of leadership or training, such as being a director of a department or fellowship, or actually have completed a PEM POCUS fellowship. Methods. In the eligibility section, you were able to include 92 experts, of whom 80 of the 92 completed round 1, as well as 64 of the 80 completed round 2. The applications included were, as you can see on the left, the 21 that were included for PEM fellows, as well as the following for PEM POCUS fellows. And on this chart, you will see the education skills, administrative skills, as well as research requirements needed for a PEM POCUS fellowship. Limitations to this study were that, again, identifying all the experts, and that there were only 40% of the initial participants in round 1 were actually completed the survey. In conclusion, core content for PEM POCUS fellowship is now defined. And that wraps up the top 10 for 2019. We'd like to thank you. Here are Julie and my children. Julie's on the left and mine on the right. As well as we would like to thank the PEM POCUS directors in the University of Colorado, including Dr. Amanda Toney, Dr. John Orsborn, and Dr. Megan Mickley.
All right. Well, thank you, Paul and Julia. That was a really nice review of articles, and it's really nice to see P2 studies highlighted there. I think that there was one question, but if everybody's okay with the response in the chat box, just to keep us moving and keep on time, I think we're going to just keep going forward. So moving on to our research platforms, our first speaker is going to be Dr. Margaret Lynn Martori, who is an assistant clinical professor of emergency medicine and pediatrics at the University of California, San Francisco. She is also the co-director of the Pediatric Emergency Ultrasound Fellowship at UCSF. And she will be presenting on evaluating a web-based point-of-care ultrasound curriculum for the diagnosis of intussusception.
Hello, let's get this on share screen.
Oh, and just one more thing. I'm just going to put the link in for the evaluation form so everybody can see that and bring that up, and just take a few minutes to fill that out.
Hello, again, my name's Margaret Lynn Martori, and I'm talking about this project we did called Evaluating a Web-Based Point-of-Care Ultrasound Curriculum for the Diagnosis of Intussusception. This was supported by a UCSF Innovations Funding and Education Seed Grant. We all know intussusception can be difficult to diagnose clinically. The classic triad of abdominal pain, bloody stool, and vomiting is present in less than 50% of the patients. Point of care ultrasound for intussusception, or POCUS-I, allows for accurate and rapid bedside diagnoses. One of the articles was mentioned in the top 10 articles that has shown this, but there are limited training materials for point of care ultrasound for intussusception. With this in mind, we developed a curriculum for POCUS-I. We used current 6 steps for medical education curriculum development, which is a 6-step process that starts with problem identification, then a targeted needs assessment, then creating goals and objectives, educational strategies, and then implementing and evaluating it. We decided to use a primarily web-based curriculum, and the link is in this QR code for the web-based portion of our curriculum, if anyone is interested. We hosted it on the ALEMU website. ALEMU is part of Academic Life in Emergency Medicine, which is an online educational resource, and there is a kind of a university component where you can take curricula and they have evaluations at the end as well. This is what our online module looked at. So first, we developed our goals, which are listed here. There was a case introduction with kind of clinical information. There was then information on how to perform an ultrasound technique with kind of a step-by-step method. There was also a repository of ultrasound images with abnormal and normal findings and also anatomical landmarks. We also had a literature review section, and then finally a quiz at the end. We wanted to also assess the curriculum, so we looked at a couple different survey tools to assess the curriculum. First, we looked at a confidence survey with POCUS-I, where we divided up the different parts of POCUS-I, including image acquisition, image interpretation, and things like that. We also developed a knowledge and image test. Both the curriculum and these surveys were developed with a group of POCUS experts, as well as radiology experts and medical education experts. And we kind of went through these in an iterative process until we came up with the final product. And then finally, the third way we wanted to assess was actually looking at the skills. So we created a direct observation checklist and then evaluated the participants on a volunteer model. So the timeline of the study was the participants were first given the survey on confidence and the knowledge and image test. They then were given access to the online curriculum, which they actually could access for the whole study. They did have a brief, less than 15-minute hands-on session just to allow for any questions and to go over the scanning protocol in person. After that, they had a post-test where they were once again assessed with the survey on confidence and the knowledge and image test, but they were also assessed with the direct observation checklist. We then waited 3 months where they had open access to the online curriculum and then reassessed them with the 3 tools. And these are our results. So at the time of this study, we had 17 possible people that could be enrolled, and all 17 enrolled. So we had 100% enrollment. 4 of them were PEM fellows and 13 were PEM faculty. Most of them had been practicing for about 6 to 10 years, and most had received some sort of POCUS training, 10 out of the 17, though most of them had not received any POCUS-I training or had any experience doing any of those scans. For the confidence survey, the confidence significantly increased and stayed high at 3 months. So only 5% of people felt comfortable performing POCUS-I at the beginning, and that went up to 76% and stayed there. When we asked questions about obtaining images, it was similar results with less like 5% up to 70% and maintaining that. For interpreting, also went from 0% to the 70s. And then went down a little bit at 3 months, but still significantly different from the pre-test. And then when asked questions about some ultrasound techniques like displacing bowel gas, that went up significantly as well from the high 20s to 100% at the post and 3-month follow-up. For the knowledge and image test, there was also significant improvement that maintained at 3 months. So at the pre-course, the scores were in the 50s, which went up to the 70s and 80s at the post-test and at the 3-month follow-up. And for the direct observation checklist, participants scored high. The median score was 20 out of 21 post-course, and then 3 months later, they were still about the same. So what these results show is that after a primarily web-based curriculum for POCUS-I, PEM physicians showed improvement in confidence, knowledge, and also performed well in technical skill for POCUS-I, and they actually maintained this over 3 months, which shows promise that a web-based platform for point-of-care ultrasound techniques can help fill gaps in training. Some of the limitations of this study is that it was done at a single institution, which makes generalizability difficult. We did not do a pre-test direct observation because the majority of our participants had not ever done a POCUS-I, so it seemed hard to kind of assess them on a direct observation without them knowing how to do it. We use the volunteer model, so it's difficult to say what effect this has on actual practice. That's actually what we're looking at now. We're going through our QI data. There's some limitations with that in that our faculty practice at multiple sites, some of which have POCUS review and some of which do not. So we'll have some limitations in that data. And then the direct observation was done by a single observer. So that's also a limitation. So our next steps are we're again looking at the practice data now, and we're also creating additional modules on the ALEMU platform and trying to increase the scale of participants to other pediatric emergency providers. I just like to thank the people who helped me with this study. So Dr. O'Sullivan is one of our med ed faculty, and Dr. Michelle Lin is the CEO and creator of ALEM and ALEMU. And these are my co-study participants here. Again, here is the URL for those who are interested. I think there was a question. How were competency questions generated and validated? I think of time. So that is probably the biggest, another limitation of this study is that, so we created, there were no like existing competency surveys for point of care ultrasound for intussusception. So we looked at ones that had been created for other point of care ultrasound applications that were published in the literature and adapted them. And we also then kind of worked with our point of care ultrasound experts as well as radiology experts to make sure that we felt that they were relevant. And I think I am out of time.
Margaret, that was really great. Anybody else have a question? Are you thinking about looking at, you said you looked at 3 months. Are you thinking at all to look past 6 months or up to a year? I know that when I talk with my faculty, one of the issues they say after refresher courses, they feel really good, but after a few months, they feel like their skills fall off a little bit.
I think that's a great question. We were not planning on reassessing them with these particular tools, but rather looking at their like actual practice patterns for kind of later on. But it's a good question.
All right. Okay, so our next presenter is going to be Dr. Almaz Dessi, who is a pediatric emergency physician at Columbia University Medical Center. She completed her pediatrics residency at UCSF and pediatric emergency medicine fellowship at Brown University and her POCUS fellowship at Columbia University. And she will be presenting on sonographic pilar staging to differentiate complicated and uncomplicated appendicitis.
Good morning, everyone. Can you give me a thumbs up if you can hear me? Okay, great. So today I'm going to be talking about sonographic pilar staging to differentiate complicated and uncomplicated appendicitis. And this was a collaborative study that many people who are on this call were involved in. So we're very grateful for your contributions, for your images and data, and I'm excited to tell you what we found. And I have no disclosures. So here is a beautiful image of a perfect, juicy, inflamed, nasty appendix. It's the perfect kind you love to see on ultrasound, and this is what I want to talk about today. So many of us, obviously, are in the P2 community, are using point-of-care ultrasound to diagnose appendicitis at the bedside. And depending on your skills and sort of your practice, perhaps you're using it to rule in appendicitis, and some of us are even using it to rule out appendicitis. And depending on your shop also, some of us, our surgeons are willing to take patients to the OR based on our ultrasound, which is great. And, you know, some of us are also seeing kind of this change in practice where our surgeons and radiologists really are starting to buy into what we're doing. In addition, at the same time, there's a change in practice that our new school of thought about how to manage appendicitis, where uncomplicated appendicitis could potentially be managed non-operatively. And we're seeing that in adults a lot, and especially in Europe, they're starting to do that with children. So that is kind of coming into fashion. And I will say, in the age of COVID here in New York, our surgeons at Columbia are now, for COVID positive patients who have uncomplicated appendicitis, they are taking those patients, they're not taking those patients to the OR, they're sending those kids home with antibiotics to be managed non-operatively. So this is particularly relevant right now. And what we wanted to look at was this idea of sonographic staging using the Pouliot method. And that is kind of an old school radiology approach to describing the submucosal layer and the changes over time of the appendix in acute appendicitis. So the aims of our study were to determine whether ED point-of-care Pouliot staging differentiates uncomplicated from complicated appendicitis in children in the emergency room. And as a secondary aim, we were interested in looking at the ease of use for providers in terms of how long it took and how easy it was, and then also the acceptability to patients if they generally tolerated it. So this was a multi-center prospective study of children less than 18 years old who presented to the ED with appendicitis, and that could be diagnosed by point-of-care ultrasound, radiology ultrasound, CT, or MRI. And then our sites performed a POCUS protocol that included the specific Pouliot staging. And then we compared these to the OR pathology reports to see if the appendicitis was complicated or uncomplicated on pathology. And then the analysis we used is chi-squared, just to look at the association between Pouliot stage and pathology report. And then for our secondary aims, we surveyed the sonologists just about the feasibility of doing this in the ED, and then also asked how they felt the patient, the family accepted it or tolerated it in the ER. So Pouliot staging is, his name is Julian Pouliot. He's from the Netherlands, old school radiologist who has published a tremendous amount about appendicitis. He has even written a textbook called Ultrasound in Appendicitis and its Differential Diagnosis. If you're interested, it's great, fun quarantine reading. And he was the first to describe this many, many years ago in terms of looking at the submucosal layer of the appendix. So this is a cross-section illustration of the 5 concentric layers of the appendix. And next to it, you see an ultrasound corresponding image. And the red stars here indicate that submucosal layer. And that's the area we're looking at that is very easily identified in ultrasound, and you're able to characterize it according to this particular staging. So here is an example of the 4 stages of Pouliot staging. On the left side, there are illustrations. On the right side, ultrasound images. So stage 1 is when the appendix is only mildly inflamed, and generally that submucosal layer is all white. It's very smooth. There's not a lot of surrounding inflammatory change. When you get to stage 2, that submucosal layer becomes much more thickened and inflamed, and there may be some focal changes. Stage 3 is sort of like that first image I showed on that video on my first slide. This is when it really becomes quite inflamed with some loss of echogenicity of that submucosal layer, and those changes are seen really diffusely. And finally, stage 4 is that appendix where you have complete loss of the echogenicity of the submucosal layer. So it just becomes this kind of black, ill-defined thing. So stage 3 and 4 are associated potentially with more complicated forms of appendicitis, such as gangrenous appendicitis or perforation. So that is the framework we worked with. For our results, we had 80 patients enrolled across 8 EDs, and 62% of them were male, and the mean age was 11.5-year-olds. 75 of those patients had the complete point-of-care ultrasound with pull-yard staging done in the emergency department, and 66 of those 75 patients had complete pathology reports available for analysis and comparison. And then the mean time from point-of-care ultrasound to surgery for these patients was just under 6 hours. So you can keep that in mind when you look at the next table. So here is a comparison of a pull-yard stage on point-of-care ultrasound, 1, 2, 3, 4, versus the pathology report. And we categorized suppurative, gangrenous, or perforated appendicitis as complicated based on some prior surgical literature and also some other studies. So of our 66 patients, 40, which is about 2/3, were uncomplicated and 26 were complicated. Of those patients who were complicated, the majority of them, 73% here, were categorized as pull-yard stage 3 or 4. And then the same was true for uncomplicated appendicitis. So 26 out of the 40 uncomplicated appendicitis were seen as stage 1 or 2 on the pull-yard staging on ultrasound. So there were 7 patients who had a suppurative appendicitis, which we initially called complicated, that had a pull-yard stage 1 or 2. But if you excluded those patients and you only looked at gangrenous or perforated, which for many surgeons is sort of how they classify complicated, just depends on what definition you use. If you're looking just at gangrenous and perforated, that pull-yard stage 1 or 2 was perfectly predictive of non-complicated appendicitis. For our secondary aims, the mean time for point-of-care ultrasound was 8 minutes, and almost all the providers felt the POCUS was very easy to perform. We also asked them how the patients tolerated it and if they accepted it, and all did in this case. So in conclusion, we found that POCUS characterization of pull-yard staging is helpful to differentiate complicated and uncomplicated appendicitis, and using a narrow definition of complicated, it was actually quite accurate. Pull-yard stage 1 or 2 to define uncomplicated appendicitis, excuse me. And this was well tolerated by patients and well accepted by them. Providers thought it was easy to perform, taking only an average of 8 minutes. So we're looking forward to looking at this more to see if we can really assess the accuracy of using pull-yard staging, and potentially in the future using that as a diagnostic sort of predictor of patients who would be good candidates for non-operative management of their uncomplicated appendicitis. And that is what I have for you today. I see one question from Andrew. We did not, so the question is if we looked at kappa amongst reviewers or how different were the reviewers. We did not do that for this study. So each site contributed their own data. We did not review those images. We just went with their report. We actually didn't do a tremendous amount of training per se. We gave kind of example images and were able to answer questions as people were learning sort of the protocol and how to categorize the images, but we didn't do inter-rater reliability at all for this portion of the study.
Are you planning follow-up studies or looking at different aspects of the data?
Yes, we have actually quite a bit more data from just this initial pilot. So those of you who participated know that you looked at many, many other aspects besides pull-yard staging. So we also looked at whether there was transmural Doppler, sort of that ring of fire, where there was surrounding inflammation, any free fluid, specific measurements, obviously, of the appendix and also of the wall itself. And we haven't actually done any of that analysis yet, though we'd like to. And in addition, we had many folks, if the patient was in the ER for more than 4 hours, we had them perform a second ultrasound after antibiotics were given. So another thing we're interested in is seeing if we can see changes on ultrasound, in a 4-hour, 8-hour, 12-hour period after antibiotics to sort of see if patients do well and improve, if their appendix improves over some time with antibiotics.
Almost for the patients who were stage 1 or 2, I can't pronounce it.
I'm not sure. I'm not sure I can either. So,
but what was the time delay from the POCUS to the operative report that you had those few patients that were suppurative?
I'm not sure I understand the question.
Sorry, so you were saying that there were a few patients who were grade 1 and 2 who were found to have suppurative appendicitis on pathology. Do you know what the time delay was for those patients, like overall in terms of point of care ultrasound to?
I see. No, we haven't looked at that specifically, although that's a good question. Like maybe they were the ones who had a 16, 18, or 20-hour delay to go to the OR, like they came in at 5 p.m. and then they didn't get the OR to the next day. That's a really good question. I'll let you know.
I see we have a couple more questions left, but we're past our questions timing. So I'm sorry. We'll keep those in the chat and bring them back. But unfortunately, we have to move on to our next presenter. Ms. Dr. Sigkarash, who's an assistant professor of pediatrics at Harvard Medical School and attending physician at the Massachusetts General Hospital. He completed his fellowship in POCUS at MGH and is director of pediatric emergency ultrasound.
Thanks, everybody. I'm going to talk about something a little different, detecting ventilator-induced diaphragm dysfunction using point-of-care ultrasound in children with long-term mechanical ventilation. Can everybody hear me and see my screen? Everybody, thumbs up a little bit? Yep, okay. I just want to thank all my co-authors who were fantastic with this. No disclosures. So as by way of introduction, advances in technology in neonatal and pediatric critical care have resulted in a growing population worldwide of children dependent on long-term mechanical ventilation and long-term home mechanical ventilation. And in the post-acute care medical setting or rehab hospital, weaning children dependent on mechanical ventilation is a common rehabilitation goal, but there's little scientific evidence in this population describing how often successful weaning is achieved or which methods are most effective. For background, long-term mechanical ventilation is defined as the use of mechanical ventilation for greater than 6 hours per day for at least 3 weeks. And children requiring long-term mechanical ventilation include those with lung or airway disorders, including BPD or tracheobronchomalacia, central dysregulation, including ischemic encephalopathy and traumatic brain injury, or neuromuscular disorders, including SMA or Guillain-Barré. And ventilator-induced diaphragm dysfunction has been very well described in adult patients requiring acute mechanical ventilation in the ICU setting, but point-of-care diaphragm ultrasound has not been evaluated in the pediatric post-acute care or rehabilitation hospital. So just for background, everybody has seen the diaphragm and moving on their lung and abdominal studies. But to review, during inspiration, the normal diaphragm contracts and moves caudally towards the transducer. And this is recorded on M mode, representing an upward motion on M mode, normal direction and amplitude of diaphragmatic excursion. And on expiration, where the diaphragm moves cranially, you can see it on M mode, resulting in a downward motion of the M mode tracing. Until recently, well, actually, let me just show you a couple pictures quickly of how we do this. This is in a patient receiving a subcostal view of the diaphragm, which is how these studies have been done in kids. Here it is on B mode, you can see the diaphragm, and on the subcostal approach, right and left, you can see the diaphragm excursion right here. Until recently, there's only been 2 studies on diaphragm dysfunction and excursion in children. These were in kids with suspected diaphragm paralysis, and they defined the normal parameters of diaphragm dysfunction. The first one was in 1994 by Ervos, who defined it as movement in the normal direction, but with reduced excursion, less than 5 millimeters. And just for reference, normal diaphragmatic excursion in a resting adult is between 15 and 18 millimeters. And then in 2005, Eppelman also agreed less than 5 millimeters of excursion in children or a difference of greater than 50% between the hemidiaphragms of excursion. And then diaphragm paralysis is movement in the opposite direction. In 2016, in the Journal of Ultrasound Medicine, Al-Halabi and group defined normal reference values in healthy children for diaphragmatic excursion in kids. And we incorporated these findings into our definition of diaphragm dysfunction. So there were 400 kids divided into their ages. They used mostly a subcostal approach. And importantly, of all the anthropometric data, including age, weight, length, head circumference, body surface area, stepwise regression revealed that only weight was a predictor of diaphragm excursion. So I put a couple theoretical dots on the graph that they used. On the x-axis is body weight, on the y-axis is diaphragm excursion. And you can see here for a 10-kilo child, diaphragmatic excursion here is about 13 millimeters, or the 50th percentile, and here 13 millimeters, around the 95th percentile. And there's a little diagram from their study. So we incorporated this finding into our definitions. So our hypothesis and objective that point-of-care diaphragm ultrasound may reveal previously unrecognized ventilator-induced diaphragm dysfunction in children requiring long-term mechanical ventilation. And as the diaphragm is the primary muscle respiration, ventilator-induced diaphragm dysfunction may impact weaning readiness or weaning from mechanical ventilation in this population. And our objective was to describe the finding of diaphragm ultrasound in children with medical complexity requiring long-term mechanical ventilation. The study was IRB approved. We included kids 3 months to 18 years of age, requiring either invasive or non-invasive mechanical ventilation, invasive through tracheostomy. They were undergoing a spontaneous breathing trial of at least 2 hours per day. We excluded kids with receiving continuous mechanical ventilation. And the study was performed at Franciscan Children's Hospital in Brighton. This is a picture of Franciscan, which is very well known in the Northeast for pulmonary rehabilitation and has a large group of mechanically ventilated kids. Our methods for diaphragm ultrasound, an ultrasound fellowship trained faculty member who was me, who did not participate in patient management, performed all the diaphragm ultrasounds. We used an M9 with a phased array transducer that was placed in the right and left subcostal areas. And the amplitude of diaphragm excursion was measured from the baseline to the point of maximal excursion during quiet breathing. We used an average of 3 measurements. And again, we defined it, diaphragm dysfunction is less than 5 millimeters of excursion and or a difference of 50%, greater than 50% from the contralateral side or less than the 5th percentile based on weight. We enrolled 24 patients over 5 months. The mean age of the diaphragm ultrasound was 4.89 years, with that range right there. 63% were male and 92% had a GJ feeding tube. The mean duration of mechanical ventilation prior to ultrasound was 1.39 years, and 46% were on a spontaneous breathing trial of less than 12 hours a day. 54% had unilateral or bilateral diaphragm dysfunction. And of these 13 children, 77% had a primary diagnosis of an airway or lung dysfunction, and invasive ventilation was significantly associated with diaphragm dysfunction compared to non-invasive. And our inter-rater agreement for diaphragm measurements was excellence with a kappa of 0.83. These are some of the baseline demographics. Again, we had 24 patients with a mean age of 4.89 years. Most of them, 75%, had BPD or chronic lung disease. And duration of mechanical ventilation, again, was about 1.39 years. These are the characteristics of patients with diaphragm dysfunction. The 13 patients, age, weight, their primary diagnostic group, the duration, the type of mechanical ventilation, and you can see the right and left diaphragm excursion. And let me just highlight a couple. This is a 6-month-old with airway lung disease, a few months of mechanical ventilation, and you can see the right diaphragmatic excursion, the little star means less than 5 millimeters, so that was diaphragm dysfunction, normal on the right. A 9-month-old with 3/4 a year of mechanical ventilation who had right diaphragm dysfunction of 3.3 millimeters compared to the right. And here's a 9-year-old with 9 years of mechanical ventilation who had 5 millimeters, which would have been defined as normal, but this little crosshatch means less than the 5th percentile, and 3.5 millimeters or less than 5 millimeters. So bilateral diaphragm dysfunction. And then the last one, a 4-year-old with central dysregulation, normal diaphragm excursion of 10.45 millimeters on the right, and met all criteria for dysfunction, 2.8 millimeters on the left, less than 5 millimeters, greater than 50% difference from the right hemidiaphragm, and less than the 5th percentile. So a couple quick examples of some of our scans. Here's a 7-year-old, 30-kilogram child, ventilated for 2 months. Right diaphragm excursion was 10 millimeters, and you can see the nice excursion here, and this is the average of the 3 on the right diaphragm. And he fit into the 50th percentile based on a weight of 30, as opposed to the left that had a diaphragm excursion of 4.5 millimeters, which was less than 5 millimeters and less than the 5th percentile. So we kind of viewed this as sort of failure to thrive of the diaphragm. This is the 9-year-old who was ventilated for 9 years. His right diaphragm excursion, you can see both are very flat, the excursions, was less than the 5th percentile, and the left was 3.5 millimeters, which fits 2 criteria, less than 5 millimeters and less than 5th percentile. And you can see it's really bilateral diaphragm dysfunction. And lastly, a 6-month-old, 7 kilos, who had a right diaphragm excursion of 3.7 millimeters, which is less than 5 millimeters in the 5th percentile. And you can see that here. And the left diaphragm excursion was 6 millimeters, or in the 15th percentile here. Some of the limitations, we had a small sample size. However, this is the first documented study of POCUS for children with long-term mechanical ventilation. We could not comment on the natural history of diaphragm dysfunction, whether it was improving or not, as we only measured at one particular moment, and not serially over time. And the application of the ultrasound probe might change the breathing pattern. However, we waited to ensure quiet breathing and took an average of at least 3 respiratory cycles. To conclude, point-of-care diaphragm ultrasound, we were able to accurately detect diaphragm dysfunction in children with medical complexity and dependent on long-term mechanical ventilation. And ventilator-induced diaphragm dysfunction and long-term dependence on invasive mechanical ventilation may be important to look at for weaning readiness and prognosis for weaning. And future studies evaluating the potential contribution of point-of-care diaphragm ultrasound on weaning readiness and prognosis for weaning on long-term mechanical ventilation should be performed. So thank you very much.
All right. Thank you, Sig. I think we have time. If anybody has one question, we probably have time for just one question. I don't know if somebody's raising their hand or just covering their camera. All right, let's everybody get up and take a good stretch, run to the bathroom. Don't take us with you. And I'm going to set up my screen, and in about a minute, we will have updates from the executive board. Any other questions, comments? All right. Okay, Ron, are you there? Can you hear me?
Yeah, I'm here.
Okay. Do you want to go ahead and start?
Are everybody okay? I don't know. What about, moving around, stretching a little? No. Okay, so if everybody feel comfortable, then I guess we'll start. First of all, I want to say thank you very much for joining us and for taking the time. This is very different from what we all imagined, and yet we have here 106 participants, which is, I think, by far the largest P2 conference we ever had. So on that respect, this is definitely a success. And Stephanie, if you can go to the next slide. I would like to take the opportunity, first of all, to acknowledge our executive committee. So Adam Sivitz, the past president, myself, Charisse, who is the president-elect, Magali Goutet, our treasurer, Erica Constantine for Education Committee, Catherine for the research, Stephanie Cohen for the conference, and Amanda Tooney, who is our communications officer. And again, especially, I'd like to emphasize Stephanie's work, which I think is extraordinary. I mean, organizing this kind of conference with all the technical difficulties virtually from almost all over the globe. Stephanie, thank you so much. This is really a great job. And, you know, I can't imagine how I would have managed with all these difficulties. If you can go to the next slide, please. So what has happened the last year? Our research is ongoing. We have the ongoing intussusception study. The lung study is in preparation and planning. We have the collaboration with PEM CRC, and it's an opportunity to tell all our members that if you have any kind of ideas, we can run it by the PEM CRC group, get their feedback to try to, if somebody needs some help in formalizing and writing a better protocol or some kind of methodological help. So we do have that support from PEM CRC for research. For education, you're going to hear from Erica in a few minutes, but apart from the articles that were already mentioned, we're going to see that Erica has put some time and effort into creating the global health subcommittee, creating collaboration with the Pure group, which sounds like a very exciting opportunity. And on the administrative side, we are part of the SCUF board, and we sit on their, you know, with their agenda and meetings, and involved in their everyday agenda. And the last item, actually, I think is probably the most important, is the establishment of ourselves as an NPO. So if you can see the next slide, the NPO is a non-for-profit organization. We talked about it last year, and by the majority votes of our members, we agreed that we're going to do it. And what happened is that we contacted Paragon Group. Paragon Group is a group that manages conferences and associations, and they agreed to give us their administrative support. And we decided that we're going to have a test period of 1 year. And during this year, we're going to see how it works, and we're going to see if they are able to support us. Now, I know from colleagues from the United States that some of the workshops have been canceled. AAP is not having the regular workshops like they used to. And this is an opportunity. So if somebody wants to organize a local workshop, Paragon has branches in the United States as well. They have in Europe, they have in Asia, they have in Africa. Oh, sorry, Kata is saying that AP is still having 2 workshops. Okay, great. But again, you can have it on top of anything that AAP has. And they are going to support us. So we're going to have this test drive of that 1 year. It's a legal thing. We're going to have to submit forms. But I really hope that it's going to make us more sustainable, and that we're going to be able to stand on our own. Next slide, please. So, Adam Sivitz. Adam is our leaving past president because we just had an elections. And before we announce who the incoming president-elect is, I want to take a few seconds and acknowledge Adam. He's by far one of the best POCUS researchers, physicians, mentors, and he has guided us through turbulent times. And I think, Adam, your leadership has been instrumental in moving P2 forward. If Stephanie can go to the next picture, I think Adam is going to enjoy some relaxing time on the beach from now instead of working. And I'm sure you're going to join me in thanking Adam. And, you know, we couldn't have done this without you. And Adam, you know, we're still going to bug you. You're still here, and your contributions are not stopping. So, you know, don't get used to resting too much. Next slide, please. We had 3 extraordinary, really, candidates for president-elect. Alan, Dave, and Sam. You know, you can't get any better than that. And the elections were pretty close. And I'm happy to say that Dave Tang is our next president-elect. Dave, congratulations to you as well. And you guys, you know, we're gonna talk every month, and you're gonna see that we have a lot of work to do, but I am certain that you are going to fit right in, and we're going to just keep pushing us forward. So, and again, thank you very much for everybody that presented their candidacy. Next slide. The next P2 conference, it's a great question. We don't know. You know, the collaboration with SAEM was wonderful. You know, I had all kind of dreams about maybe dragging everybody to Europe and, you know, having you see the other side. Yeah, exactly. And having you see the other side of the ocean. And we, you know, we still have that fantasy. Maybe with a collaboration with Paragon, maybe we can make it happen. Maybe collaborating with the USIM, the European Society of Emergency Medicine. A lot of possibilities. These are uncertain times. But just like you saw that we eventually, whatever happened, we still had the time and the opportunity to meet, even if it's a virtual conference. I'm sure we're going to have it next year as well. So again, thank you so much, everybody. Really, I want to thank all my colleagues, all the executive committee members. I want to wish a lot of success to Charisse as the incoming president and Dave as the president-elect. Stephanie, I'm having, you know, a great time just as if this is a regular conference. So thank you so much, and hope to see you, you know, and give you like a true hug next year. Thank you, everybody.
All right, so next we're going to have Magali Gauthier give us an update on the treasury status.
Hi, everyone. So I'm your treasurer from Switzerland. And I just wanted to, you can just switch to the next one. So just that like very, very short bit of picture or the perspectives of our fortune over the year. So we started in 2014, and in green, you can see the incomes, in red, the expenses, and then in blue, the balance. So first we started pretty high. We had actually a lot of vendors giving us money. And then otherwise the money comes mainly from conferences. So I guess from the conferences, we got a lot of money in 2018, 2019. And then it kind of like went down. And for sure this year, incomes are not gonna be very great. But I mean, expenses probably too. So we'll see how we end up the year. But so if you just go to the next one. So what to, yeah, perfect, thanks. So what to expect for 2020. So we start with 1,300 Canadian dollars in our bank accounts, and we are still expecting some money from GE, which is kind of like stuck at Sick Kids. So probably we'll have around 3,000 Canadian dollars, which is probably what we're going to need to transition into an NPO. And then on top of that, we still have some management of the website, some admin stuff to do, some like teleconferencing costs too. So for now, Sick Kids has been helping us a lot, and a lot of the website and admin stuff, they are taking care of, thanks to Jason, really, and then Kelly for the admin and Veronica for the website now. But we'll probably need to take care of that in the future, so we'll need some money for that too. So there is a lot of questions right now about fundraising, and we might, like by transitioning into an NPO, we might need some memberships. And we'll see then how to do that the best for everyone, for sure. It's not going to be very expensive, don't worry. But just for us to stay as an NPO and just get stronger, we'll probably need all of us just to invest a little bit of money in our P2 network. So that's it for now. why was GE giving some money? It's just vendors, they give money on a regular basis. For what exactly, I actually don't know. I don't know if Ron, maybe you know.
Yeah, it was a sponsorship of the previous conference. So in previous years, we had Mindray, GE, Philips. They all, kind of sponsored. They got a short time to talk. So that's why they were giving the money.
Okay, there it is, I guess. No other questions, right? Thanks.
Hi everyone, so I'm going to do our research updates. There's a lot of great projects going on. I'm going to talk about a few of them and then ones that are looking for sites to enroll with them. And a lot of them, most of them are in the newsletter, so if you're interested and you don't catch the email address, you can just grab it from the newsletter. Do the next slide. So there's a group of us, Sam Lamb as a lead, and we're working on a manuscript kind of describing our P2 network. So goal is to establish the missions and visions of the P2 network and kind of formally introduce us to the world with the hope that we can kind of refer to this in the future for manuscripts and grant applications. And so, we're kind of covering POCUS and PEM, our P2 formation, the need for the pediatric POCUS network, and focusing on education and research. So that is in manuscript production right now, getting close to being finished. Kelly's still working on the point of care ultrasonography for intussusception. COVID slowed enrollment, but he's still enrolling. They've had 183 patients enrolled, and 2 new sites were added, DC Children's and a site in Australia. And so target hopefully now is going to be by winter of this year. I think Adam, Stephanie, correct me if I'm wrong, but Adam's going to talk about this soon.
Yeah.
Okay, perfect. We'll skip this one. Sam Lamb and Kirsten is still working on their pediatric thoracic trauma study. Again, if you're interested, please contact them. COVID has kind of stalled enrollment, but again, contact them for further details. And then Sam is also interested in looking at point of care lung ultrasound for sub-centimeter consolidations, but is hoping to find a PI. So again, anyone that's interested, please contact him. And then there's a group of us getting together just to look at point of care lung ultrasonography in patients with COVID, given we're starting to see a lot more, and especially this multi-system inflammatory cases. So if you have any ultrasounds on any patients with known or even suspected COVID, please just shoot us an email. We'd love to get kind of a case series together and then potentially look at prognostic value of lung POCUS and compare them to radiology imaging and lung ultrasound pre-COVID. And then David's still working on his appendicitis imaging, and I think he also updated me. They have 90 subjects enrolled, and so they're still working on their analysis and then manuscript preparation. Charlotte, again, is still working on optic nerve sheath diameter reference ranges. Again, if you're interested in participating, just shoot her an email. And then I love this title, The Peanut Butter and Jam. So they're looking at the diagnostic accuracy of point of care ultrasound for diagnosing pediatric esophageal foreign bodies. And so if you're interested, Danielle is the lead, and so please shoot her an email. So again, we provide general mentorship, research protocol feedback. If you want to be featured in the newsletter, if you're looking for other sites to get enrolled, please contact me. If you are interested in developing a P2 Network sponsored study, contact me as well. I know we have lots of great studies going on, so I'd love to hear about them. I think that's everything.
All right, am I up? Can everybody hear me? Okay.
Yes.
So some education updates for this year. I think the most exciting, you can go to the next slide. The most exciting for us is our new global health division, and it's been a little bit of a work in progress just to get the nuts and bolts set up. So our first goal was really to develop the mission statement of the division And we came up with enabling global sustainable pediatric point-of-care ultrasound diagnostics in resource-limited settings. And as part of this, we really had to set up a few subcommittees that were each responsible for doing their share in getting this mission statement off the ground. If you want to go to the next slide. So we set up a few subdivisions. So our first subdivision is our fellowships and special projects. And this one's being led by Eric, Michelle, and Jiska. And the goal of this subcommittee is really for a kind of bi-directional sort of training in resource limited environments. And that's for us to send our fellows and trainees to resource limited environments, but also to figure out how to support the educational needs of people in resource limited settings to see how they can get point of care ultrasound up and running. Next slide. So we have a curriculum development team as well that's led by Antonio, Tal, and Gerardo. And the goal of this team is really to set up an online educational tool that can be accessible to everyone. And we're working on figuring out the best platform to make this available in. And also there's a great effort to make this multilingual. So it's not only going to be in English, but we're going to figure out, there's, currently we're working on translations into Spanish, and we're looking into other languages as well. And so we're going to have to figure out the real repository for all this educational content, and we're going to figure out a great place to put it and make it accessible globally. Next slide. So we have a research team that's working to support global health research, and Almaz and Lori are both heading up this team. And their goal really is to become the point people for coordinating research in the global health field. So that's what their goal is. Next slide. And then Danielle Paulin is going to be responsible for coordinating all the grants. So if you are aware of grants or if you are in need of a grant, she's going to be your point person. Next slide. So as part of this, you know, all of you might be thinking that there is another organization out there that has a similar goal, and that's the PURE network, which stands for Point of Care Ultrasound in Resource Limited Environments, and it's led up by Trish Henwood, who's currently in Philadelphia. And because we didn't want to really reinvent the wheel with this division, we're actually collaborating with them for pediatric content. They are desperately in need of pediatric subspecialists to help with their content. So we're actually collaborating with them to make sure that we, you know, have the best tools and that we're not duplicating our efforts. So that we're going to be collaborating with them to help coordinate some of our projects as well. So that's the global health stuff. In terms of the other educational endeavors, I think one of the biggest roadblocks to getting our educational content all in one place is our website. So I'm in the process of working with Veronica Jennings out of SickKids to redesign our website so that we can have a good central repository for all the pediatric POCUS content. And I've reached out to all the chairs of the individual subcommittees so that they can all help us get that content up and going. And that's it for my updates. If you want to go to the next slide. If anybody wants to reach out to any of, regarding any of these things, my email is down at the bottom. And I just want to say a quick word about this photo. I took this photo at the end of February, and the goal of this photo was the "Don't grow up, it's a trap" part, because I think as a pediatrician, I'm kind of jealous of kids because it seems like they often have more fun than adults. But when I looked at this photo again over the weekend, the quote at the top really struck me, where it says, "All great changes are preceded by chaos." And I think at the moment, that quote is probably a lot more meaningful to most of us. And I hope for this group and for everybody that we can all manage to see the silver lining in this, and that some great changes are going to come as a result of it. That's all I got.
All right, thank you, Erica. So, you know, obviously this was a big disappointment in our not being able to get together, but I think that's just to say the least of it with everything that's been going on. So generally, the conferences have been really, really put together mostly by the executive board, you know, organized by the conference chairperson. But moving forward, actually, the plan is to create a conference committee. So I get a committee too, so that we can increase input and involvement from members of the network, and so that we can reach out and include more people, make more teaching opportunities, but also create the conference material that everybody wants to see. So my email's been floating around. I didn't put it in this presentation, but we're going to send out an announcement later on with the evaluation link again. And so if you want to get involved in creating conferences, and I put down here remote meetings throughout the year, you know, we definitely want to get together in person, and that's really the best way for us to interact and get involved. But right now, remote is our only option, and you know, maybe we'll do more of these conferences throughout the year. So please reach out to me, and I'd really like to see people get involved. All right, so we just have 3 announcements of from members of studies that they are doing, and I'm going to call Laura Malia to announce her study.
Sure, thanks. So I'm from Columbia, and Dave Kessler has been the main head working on this study, and became involved last year. But soon we're going to be looking for participants, although it may be somewhat similar to the study that we just heard about, which was a really cool study. We're looking to get medical students, residents, fellows, and attendings, looking at an online platform for identifying intussusception on ultrasound. And it's going to be on a similar platform to ImageSim, if any of you or any of the fellows have used this in the past. And the idea is we're going to be looking at kind of ongoing learning and ability to learn about POCUS Intussusception within this platform. So you can see my email, and one of the research coordinators' emails is there. If you want, feel free to email us, and we'll keep you on a list. Otherwise, you'll definitely be hearing from us in the future soon. Thanks.
All right, and our next announcement is from Adam Sivitz, who I think everybody's already given a round of applause. Adam, thank you very much for your help and mentorship.
All right, thanks, Steph. And this has been a great conference. Great job putting together, and very happy to see so many faces I haven't seen in a while, and looking forward to seeing everybody in the real very soon. So this is my announcement for the P2 registry. So we already kind of talked about the intussusception study that's ongoing, and the lung projects that are also in process. And so why were we doing these things? Well, back when we all started about 6 years ago, we put out a survey asking what was supposed to be like our research focus group, and sent out, you know, the whole survey, a bunch of choices, and the 3 things that came out on top were to look at intussusception, lung pathology, and then cardiac arrest or shock. And we actually had like a cardiac arrest shock working group for a little while. It was going to be a hard study to do prospectively. So we got the idea of trying to create a registry to collect these cases retrospectively. And eventually, you know, it obviously hasn't like panned out as planned, but, you know, I've been kind of working on it in the background, trying to build something for cardiac arrest shock. And once I started doing it, just decided to put all the rest of the things in there. So I'm just going to talk about that real quick. Stephanie, you can go to the next slide, which I think I've already kind of talked about, so go ahead. So a lot of the frustration with collecting data comes from different, you know, processes that we all have. So some of us like, most of us hate our EMRs. You know, we all have different third-party image storage solutions, which, you know, with recent updates, I'm not sure how happy we are with those. All our fellows have procedure logs that we can try to collect and retrieve cases to see what we do and how we do things. And then there's billing data for sites that are actually at that stage. But obviously nothing here is uniform. We all use different versions of this. And, you know, part of the idea of P2 was to try to like do things together and collect things together. Let's move on to the next slide. So the idea of having this registry put together, you know, for the group and ideally by the group, it's still for tweaking, is to have an organized, systematic way that we are collecting group-wide data with outcome-oriented data points. Can move up.
Sorry.
So what this is definitely not is anything looking for any kind of PHI or image storage solution. Both of these things are instant non-starters. Anytime any place is going to start talking to their own hospital admin or IT solutions. So, let's just cut that one out for a second. Next slide. So the potential for having something that, again, is kind of like organized by the group, designed by the group, and for the group is that you can expand on this. So, for most of our studies, we're all using REDCap platforms, and the registry is built on a REDCap platform. And so it has the potential of being able to be, a data collection tool for, anybody's research projects. Move on to the next slide. And so just to give people a quick look at what we have so far, I designed it to try to balance simplicity and data. We've been tooling it around at our site for a while. Most of my fellows tell me it takes no more than about 100 seconds to go through any of these things. As I mentioned before, there's no PHI, so I'm not asking for MRs. The ages are deliberately vague, so let's not get into problems with compliance there. You can't see the application list on the right-hand side, or at least I can on my screen, but it does include pretty much everything that we would be doing with ultrasound. And Stephanie can move on to the next slide. And so the questions we ask, it's everything that's been in any of the reporting tools that have been published so far to date. The things that I've also added are some of the outcome-oriented things more for us. How helpful was this for our regular exam? And some a little bit more drilled down detail into how it was helpful. Were we eliminating labs, imaging, reducing the length of stay, those sort of things. And on the right-hand side, the billing for POCUS was supposed to be my way of differentiating educational versus clinically directed ultrasounds. And there's a note section for anybody that wanted to use this and include data, kind of separate from what I've already asked. So you can move on to the next slide here. So the data is, the project's being run through Rutgers University. One of the questions is what site is submitting the data. So there's a scroll through. I have about 120 hospitals in there. People have said, I'm not on there. I can add it on, and you'll be in about 30 seconds. And again, since there's no PHI, the data is all anonymous for people who want their data back. If you're putting data in, I can give that data back to you. It doesn't take more than a minute or two to extract it. So this is open to all. And again, the idea is for everybody to be able to use this. So once we have 20, 40 centers, you're doing 500, 1,000 scan a year, this is going to create a data repository for us to answer some important research questions, find out what we're doing, how we're doing, and how important it is. And I think this is very important for us as a group going forward. So we can go on to the next slide. Okay. So on my screen, again, I can't see the entire shortened web link, but it's bit.ly/POCUS-REG, R-E-G. So anybody can just type that in, take a look at it, play around with it, comment on it, and start using it kind of as you would like to. And we can move on to the last one. And so questions. And maybe before the questions, I'll just add one last thing. This has been, I'm outgoing here, so this is my 6th year. I've been here for all the years of P2. As I came in as the president-elect way back when. And this is one of the things that I was really hoping to get done during this time, and would like to still continue to try to get done even past my time. So for anybody that's interested, I know that other places have created homegrown solutions. That's great. I don't want to reinvent the wheel for people, but I do think it is important for us as a collective group to start doing this sort of wide-scale data collection for all of us. And so for those of you who have things together, and some of you have contacted me offline about this, that's great, but let's put our heads together and do something to help us all out. All right, and that's it, and I'll pass things along. Thanks, Stephanie.
Thank you, Adam. We're running a little bit behind schedule, so Marjan, I'm sorry we're going to have to pass on your presentation, but I just want to mention that there's one other study looking at education for pediatric residents, and we're going to put that in the newsletter. I want to take just 1 minute, something that we always do when we get together at our conferences is we always get together and take a picture. So I want to ask everybody just to start their videos so that we can get everybody on screen. And I'm just going to scroll through all the different pages. So as everybody can and I'm going to scroll through then. This is going to unfortunately be our group picture for the year. Hold on, it's not scrolling. And you can wave too. Oh, still some people don't have their videos on. All right. It's good to see everybody. I don't know how you're doing that, Alex. All right. So for the last, hold on a second, sorry. For the last session, there's been a lot of discussion about, everybody is talking about COVID and what we're seeing, and the pathology. I'm looking in the chat box, and everybody's talking about who's seeing this, what's everybody seeing, and I know that our New York colleagues are certainly seeing, much different pathology than the rest of us around the country. But what is affecting all of us is, how this is really affecting our POCUS education. So I wanted to take this last 30 minutes of getting together, and we put together a panel of some of our colleagues, members, and just to see if we can kind of brainstorm about, how, find out what people are doing, and see how we can help each other get through this time. So I've heard several people mention that 2020 is the year of disruption, and I think most of us can agree that we're just don't even really know what's going to happen next week, next month, in the fall. Everything seems to be kind of up in the air. And that's really had a significant impact on our POCUS practice as well. Everybody has seen POCUS rotations canceled, and even for those who are going into the hospital, we're still limiting educational scans, all of this in an effort to decrease transmission. And also there's a lot of discussion about contaminating the ultrasound machine and then transmitting infection that way. Many physicians have lost academic or protected time because they are covering in other units or covering their sick colleagues. And research has been stopped in many institutions. And then many of us have gotten sick and actually have not been able to work. And so these have been pretty significant. So in this last 30 minutes, we're going to describe some of the challenges that are affecting us in terms of our POCUS education, highlight some programs that have been successful in adapting to the situation, and then look at lessons learned for adapting in the future. So, I mean, POCUS is I think, a little bit more challenging as far as adapting to remote education than just our regular fellows curriculum, because it really relies on, it's a hands-on skill, and there's a lot of pattern recognition. Our fellows have to, oh, somebody, can you, I can't see who's got they're muted. Just make sure you mute. Anyway, so just again, a lot of hands-on skill. So I just want to put a poll there and find out what is going on in your institution in terms of changes in education. Are you guys continuing with your education? What adaptations have you had to make? All right, I'll give you guys just a few more seconds until everybody gets a chance to answer the poll. All right, I'm gonna end that poll. So we can see that a majority of us, we were able to adapt to online sessions, but we're not really able to have any hands-on sessions. Just 2 programs have continued their regular educational program. But again, most of us are having significant changes. Can you guys excuse me just 1 second? Let me just see who's talking.
It's Sheetal, 70.
I know. I can't find him though in the
He's good. She's
participant.
good. She just muted it.
Okay. All right. Thanks, Alex. All right. All right. So I guess we're looking at, so how can we adapt to remote education in an era of social distancing? How can we be successful with educating our learners? So in order to answer the question, the first speaker that I want to introduce is Dr. Liang Liu, who is an assistant professor of emergency medicine and ultrasound faculty at Emory University School of Medicine. And she'll talk about a program that was developed here in response to the COVID infection. They developed a national remote learning curriculum that is being used by over 11 different residency programs around the United States. So Dr. Liu?
Hey, can I screen share?
Yeah, do you want to, or I can just run it for you?
Oh, perfect. Go ahead. Hi, everybody. It's great to see you guys virtually. So I want to talk a little bit about what we did. So in mid-March, we pulled our rotators from our rotation. And so we had 3 learners at that time, and kind of moving forward, we wanted to see, we have the fortune of having a lot of ultrasound faculty, so we were still doing remote sessions with each of the learners, but it just seemed kind of silly to have 11 faculty involved very intensely with just 3 learners. And so my partner in crime actually sent out a message to the ACED's ultrasound section, just asking different programs who would be interested in combining forces. And you can go to the next slide. We were fortunate to get a ton of participation. So we have learners from 11 different institutions and 14 total institutions collaborating. So even those who don't have learners anymore, we got faculty who would be able to teach our learners. Next slide. And so this is our May schedule. In March, we kind of just made up what we can. In April, we were able to pilot our curriculum, and basically you can see the first 2 weeks are really focused on our basic topics, and the goal of this was really to focus on our intern curriculum, but we actually had participation from fellows, postdocs, medical students as well. So the first 2 weeks are focused more on our basic ultrasound. We have a few repeating topics throughout, such as echoes. We know that that takes a little bit more teaching, and then gallbladder also just is a little technically difficult. So the latter 2 months or 2 weeks are more focused on more advanced skills. Next slide. And so the setup is that there's daily pre-work for each of the topics. And then the sessions are 2-hour flipped classroom style. So the expectations are learners have already read or watched videos online, and they join a faculty member for 2 hours with a focus on highlighting important topics, and then also then focusing on QA and looking at case-based learning. The institutions also, depending on the institution, have individual sessions in which they're working on scanning. And we also were able to get the Butterfly Network to donate 2 ultrasound probes per program. And so we were able to get ultrasound butterflies probes to each of the learners, and so that each of the institutions can do some scanning sessions as well. And that is a pool QA database too. So now we have images from the various institutions that we can QA, just depending on whichever faculty has the time for it. And there's kind of a range of, some programs are doing 2-week rotations, 1-week rotations, 4-week rotations, but on average, we're having about 9 to 19 learners per session. Next slide. Here's kind of an example of our curriculum. So that's the first 2 days of this month. So their pre-work, who's going to be in charge, and kind of our objectives for each session. Next slide. In addition to that, just to keep people engaged, as it can be pretty impersonal via Zoom, we have some gamification, so Jeopardy sessions, Kahoot sessions, and also our colleagues at Hopkins created this kind of quarantine POCUS challenge that's kind of is fun, but also highlights some of the important key points for each of the sessions. Next slide. So this is the breakdown of participants. As you can see, the majority of our learners are our interns. We have a few medical students, a few fellows and faculty, and one stenographer as well involved. Next slide. And this is kind of just how many sessions each of those learners, of course, all the faculty I took out of this easy graph, but of our learners, how many are involved. And so you can see some of them are just coming in for a few sessions. There are those who are doing 1 or 2 week rotations, and then those who are on a month-long rotation as well. So it's been a great collaboration. I think we had a lot of participation in April. In May, as the programs are starting to open back up, we have fewer in May, and we're still talking about, you know, what's the critical number of learners if we were to continue this session in June. So I have, through our curriculum, I'm very confident that our learners are really good at scanning themselves. And so, of course, there's still going to be a remediation plan to kind of, for them to look at pathology and be able to scan patients who are not going to be their excellent body habitus and cooperation that they currently have. So thank you.
And Liang, you're also looking at satisfaction from the residents and how they felt that this program worked for them.
Correct. So the next steps are we're sending out a survey to kind of evaluate, one, how effective this was for the learners and also the faculty. And also we kind of want to quantify how much time do you normally put into your POCUS rotation, and comparing that to now via this virtual curriculum, and what opportunities there would be for collaboration even outside of this COVID environment.
Thank you very much, Liang. So our next speaker is Michelle Lee from Hospital for Sick Children in Toronto. So Sick Children, they've been publicizing their weekly conferences for several years now. And Michelle, can you just comment on, oh, sorry, go ahead.
Sure, sorry, I was just about to share my screen. Please continue.
No, go ahead. Just, so you've been very successful in your conferences, and just tell us a little bit about, you know, what you found is working for you, and some of the, I guess, successes that you've seen from the situation.
Sure, of course. Thanks for having me, Stephanie. So I thought I would just start by giving some context around our PEM POCUS Fellowship Program, for which I'm the interim program director for. So we run the only PEM POCUS Fellowship in Canada, and every year we have 2 to 3 fellows. This year it's our lovely Maya, Imbal, and Maud. And throughout the year we have many trainees coming on elective from all around the world, and there's usually 2 to 3 trainees per month. Our traditional structure has been a heavy academic day on Wednesdays, where we do in-person weekly lectures, we do journal club, image review, and then we have multiple scanning shifts dispersed throughout the week. And in the background, there's always the many longitudinal online resources that are readily available 24/7. Of course, when COVID came along, we had to stop all educational and research scans in our ED. So our educational activities definitely took a hit, and we had to cancel all our scanning shifts, and our Wednesdays can no longer be in person. But thankfully, we already had infrastructure in place to broadcast all of our Wednesday lectures, even before COVID era. So there weren't any major interruptions. We just continued doing them on Zoom. And a silver lining in not having the academic days in person anymore is that it took away that geographical restriction, and suddenly it made a lot more sense for us to have more international guest speakers give lectures. And many of you on the call today have kindly agreed to, on very short notice, to be our lecturers. So thank you very much for that. Just last week, we had a multi-site rounds titled POCUS Cases Around the World, where we had a record 57 participants from many different countries joining in. And the feedback of these increased international presence and talks have been really great, since people have really enjoyed having exposure to a more broadened spectrum of pathology. For example, we've had only a handful of COVID cases, but not a lot of POCUS findings. But when the New York partners were able to join us in rounds, we were able to see examples of that. And overall, people have just really expressed expressed that they appreciate having a regular forum that's open and available for whenever they're free for knowledge exchange while their home institution's academic activities may have been interrupted. Now, in terms of the scanning shifts, instead of outright canceling them, our fellows have found creative ways to lead these online for our rotators. They're giving lectures on core POCUS topics, they're reviewing cool cases from our building image bank, or doing QAs on old scans that are stored on our QPath. We're also encouraging our fellows and trainees to make more use of all the longitudinal online resources. Our website and YouTube channel has been generating more and more traffic. And there are, of course, the plethora of online FOMED resources that are available that you probably all already know about. Another online learning platform that's homegrown at SICKIS is ImageSim, which is an interactive online bank that has 4 core POCUS modules. And each module has 100 cases, 50 normal and 50 pathology. And I just have a sample clip there for those that are not as familiar with the platform, that it's quite unique in a sense that it gives a trainee a STEM, and then it asks them to commit to an interpretation. And then once they've committed to it, they get immediate expert feedback on their answer. So it's a great way for trainees to gain exposure to pathology and gain confidence in their image recognition skills from the comfort of their own home at a time that's convenient for them. So I'm maybe going to stop there in the interest of time. We definitely don't have all the answers on how to mitigate the effects of COVID, since it's definitely still taking quite a big hit on our academic activities. But hopefully hearing about what we've done will give you some ideas on strategies to try out. So thank you for your time.
All right. Thank you, Michelle. Oh, sorry. So again, this gives us lots more questions. You know, when are our rotations going to go back to normal? Are there advantages to remote learning? How are we going to remediate our trainees who had their rotations during this time? What do we expect will continue from this experience? And how will this affect us as faculty who are going to be continuing to teach POCUS? So I just wanted to ask Delia Gold, who was part of creating part of the Delphi study on the curriculum, to just give some of her input into where some of these new directions will lead us. Are you there?
Oh, sorry. Hi, sorry about that.
It's
Thanks,
okay.
Stephanie. I think that funnily, my lack of PowerPoint that is actually pretty demonstrative of what's happening in my educational life in the COVID era. And that is essentially not much. My institution took a very kind of aggressive angle on quarantining, testing, locking people down, and not letting people do anything educational. So I was in the group of people who got their time taken away for at least the first month and a half. And now I'm currently trying to pick back up the education. So if anyone felt jealous of Dr. Liu's presentation, like I did, I am trying to kind of catch back up. So for what I was thinking is that I feel like this, in line with what Erica said, this is a great opportunity for us to start trying to think outside the box. And collaborative efforts is definitely the way to go, in my opinion. I am affiliated with a large adult hospital that has been which I've been helping with their curriculum, which is a lot similar to what Dr. Liu was talking about with, flipped classroom learning. The learners all have butterflies. We go over their scans, we do QA. And I think for the intern, we kind of have to think differently about our education. It's not as much going to be these educational scans where you just walk around the department and kind of show off the cool things that you can see with ultrasound. And we're going to focus, at least I'm going to focus more on image interpretation, which I do think is a very interesting aspect of what we do. As a somewhat newer field, we think of ourselves as trying to make sure that we can acquire our images as well as interpret them and then make a clinical decision on it. And for the older attendings, at least in my department, they are not comfortable with acquisition, and I don't know that they ever will be. But what I do think they would be comfortable with is image interpretation. And so what I've found is after that month was over, and as I've started to pick back up on the learning, I now have a lot more attendee buy-in on these Zoom meetings, probably because it's easier when you don't have to go anywhere. But it does seem that they're very engaged in image interpretation, and I still, because they could see it better on how they would use it for clinical management, and they aren't as intimidated about the hands-on portion. Obviously, they'll need to be remediation once this time period goes through and we're allowed to kind of be with our patients for longer. But I think that that's one of the angles that people will be focusing on. There may even be opportunities for studies in that area. I don't think, pretty much I'm doing the same things as everybody else is doing now that I could do it again. We're limiting educational scans. We're really asking the question of, is there utility to doing the scan, which I don't feel that I used to ask, but now I do because of the strict kind of quarantining rules my hospital seems to follow. They're very quick to knock us off the docket, so to speak, and the guilt associated with that makes me really question when we should be scanning these patients and if it's going to have use. And regarding research, obviously for everybody else, it has slowed down anything that we're doing that has to do with in-person interaction. But since most of my stuff is medical education, it hasn't really made a difference for me.
Actually, that's on our next, for those who are left, I can hear people leaving. But just our last poll that I have for the group is on what is the status of research in your institution in this current pandemic? So I'm going to let the poll go for about another 10 seconds. We still have a few more people to put their vote in. All right, all right, but you can see that most of us are in our institutions are not able to do research right now. So in our last just couple of minutes, I just wanted to introduce, this is one of our ultrasound faculty demonstrating our socially distant enrollment with his barcode t-shirt. But just ask Sam Lam just to give some recommendations for what we should be doing right now with research solutions. Sam is a past research chair for P2. He's also the clinical associate professor of emergency medicine at North State University. And he's writing a joint statement on for ACEP and SAM.
Hello there, everybody. Can everybody hear me okay? I just assumed that.
Yeah, okay.
Excellent. So yeah, thank you for giving me so much time to Google how to change my Zoom background. I think I can probably try it on my next Zoom meeting. So I'm gonna be a little bit brief because I know we're running over a little bit. And Stephanie asked me to talk about how to adapt in this COVID-19 era, you know, how to adapt a research protocol, how to do research in this era of COVID-19. So as we've talked about a little bit more before, the major challenge for me actually at this point is actually the lack of patients. For those of us who do clinical research on ultrasound, we have to have patients. And from who I've been talking to, people have seen like huge decrease in pediatric ED volumes, at least 50%, if not more than that. I've heard people that have volume down 60%, 70%, even 80% of pediatric ED volume. And the lack of pediatric patient, it's a huge barrier in doing clinical research. obviously. We've heard people talk about decreased protection time. We've heard about institutional ban on, quote, non-essential research, which means that everything that's not COVID-related is banned. In my institution, and I'm sure in many other institutions as well, we have banned non-essential personnel, i.e. all those research volunteers that throw the board and do consent for me in the ED for various clinical research studies. So that's another devastating step. And as ultrasound director, I'm always worried about passing on infection inadvertently because I didn't clean the ultrasound machine properly before doing a research study. So that makes me think twice about enrolling somebody for a research study, even if I have the means to do it. And actually, full disclosure, in our institution, there was no banning of ultrasound research. They took over a research volunteer, but we are still able to do ultrasound research as is. And in fact, I just got one of the protocol approved by our IRB. So we are actually fortunate that way. So as most people know, most people that have done research would know, research, it's not just recruiting patients and collecting clinical data. There's a lot of background work going on in doing research, and this can still go on at times of COVID. In fact, if you have a little bit more downtime, you might want to work on developing your pet project protocol. You might work on doing an ILB submission. You might work on getting your grant application, which you've been putting off for a while, because grant applications, to me, is the one that takes the most time. And for those who have completed some project, you might want to do some data cleaning, do some preliminary data analysis, and see if there's an interesting trend, and even start writing manuscript, which is another big hurdle on doing your research and getting your research out there. Now, there's certain things you probably can do to sort of make your research project better, and I call them research hacks, or enhance your research skills as well. Now, before the COVID era, remote consent is unheard of almost. But now, because of all those COVID protocols and the removal of research assistants or research volunteer from our institution, it is fairly common. So if you don't have the remote consent clause or remote consent terms in your research protocol, I would advise maybe adding it to your research protocol at this point, because down the road, when the volume resume, it would be very helpful to enroll your patients, especially when you or your research assistants are off campus. You can now do remote consent, and people that know how to scan can just scan, and you can just do the consent without actually being physically in a hospital. And I see that as a way to increase enrollment of your research subject. If you have a decontamination protocol for your POCUS machine, Ellen actually sent out an email, I think, for our POCUS Gmail group asking about that. If you actually have a decontamination protocol in place, I would advise you to put that in your research protocol as well. That shows the ILB and shows everybody that you're submitting protocol to, that you actually care about your patients and you actually don't want anybody to get hurt, and it actually looks good on your protocol. Obviously, if you're like everybody else, if you have decreased patient volume, it is time to look at collaboration with others. You might want to work with other people to increase your recruitment to help finish your project on time, and P2Network is a great platform for doing that. I'm not on the IRB or REB for my institution, but I did reach out to my IRB, and to my surprise, the IRB in my institution, it's actually working overtime, mostly because of the sheer amount of COVID-related research that needed expedited approval, expedited review, but probably also because some of the IRB members have a little bit more free time to look at a protocol as well. So I should reach out to my IRB and say, hey, I've got a protocol stuck in the IRB submission. Can you please look at it? And actually, I was surprised that they sort of fast track it and get one of my protocol approved. And we're actually getting ready to submit another IRB as well. So while you having your research projects on hold, I think submitting IRB might be a good time for doing that, because the IRB is actually very active in the background. Of course, we talked about this in our previous seminars and previous didactics that the COVID is so new and there's so many things that we don't know about it. Even a case report, a case series would be accepted for journal publication, whereas normally it wouldn't. So this is an area great for doing research. And even if you are not just doing COVID research, and that suggestion, I would say it's to look at your colleague that are doing COVID-19 research, because if you can try to work in a COVID POCUS ultrasound protocol, that would sort of enhance the sophistication, that would enhance the collaboration component of your research project. And I think this is a great way to get funding for research, given the amount of funding that's out there. And talking about funding, if you really, really want to do research, you can't think of doing anything else, you might also want to just jump into COVID-19 research as well. That might not be POCUS related, because there's so much funding out there. Lastly, I put together a list of some of the resources talking about funding. Both the SAEM Foundation and the Emergency Medicine Foundation have come up with COVID-19 research grants. And if you look at their website, they will give you details. The deadlines are pretty close. I think a few of them actually due in June 1st. But if you have a good COVID project, you still have time to put together a protocol and get funding for research. And also the SAEM Foundation has an ultrasound research grant under the Academy of Emergency Ultrasound. That's $10,000. That is due on August 1st. So you might want to submit that as well. Recently, the ACEP and SAEM have put out a joint statement of research in the time of COVID, the idea of which is to give people a sort of a best practice, an idea of best practice in this era of COVID. And it is listed under the ACEP website in the COVID-19 field guide. And you want to take a look and sort of give you step by step on what the institution or the investigator or kind of a professional organization can do to help researcher in this era of COVID. And finally, there is this Council on Government Relations website for those of you who actually are thinking about getting government funding, so even institutional funding. This is a great clearinghouse on COVID-related modifications and changes, or RFP for all those governmental agencies, as well as some private institution as well. So that's a good way to look at what's been happening in the COVID era. That's all I have, and thank you for sticking around.
Thank you so much, Sam. Those are really helpful resources. And somebody just asked me about getting out the websites. We will. If you, Sam, want to share that with me, we'll get that out to the group, but if not, we'll get it out later on.
Yeah.
All right, so I think, we pretty much passed our time, so I just want to wrap it up. Actually, before I do that, are there any questions or comments? Anybody? I don't see anything in the chat box, so I'm just going to close up. I just wanted to, this is a thought that's been going through my mind for the last couple of weeks. Although we are far apart, we have never been closer together. We meant to be together at a conference in Denver, and we're scattered across the globe, but it's amazing that we have been able to get together remotely and, talk like, we're next door. We'll send out the evaluation link as well. Please fill it out. This will be really helpful to give us feedback about how this conference went and how the remote platform was, and just help us just to prepare conferences coming up. I want to thank all of our presenters. You guys did an awesome job. Really made this conference fantastic, and special thanks to Kelly Sobey from Sick Kids in Toronto. Without her, there's no way we would have been able to do this today. And Veronica Jennings, who was instrumental in helping with the technology. I know that Ron said, we don't know what our plans are for next year, and I definitely echo that. We were planning to partner with SAM this past year, and they still invited us to come next year, potentially to do our conference in Atlanta. we'll see what happens, but you know, please join our conference committee, and we will get this together. Any that's it for me.
Well, thanks everybody. That was awesome.
Okay. Ron, do you have any final last words? Anything you want to share?
I just want to say thank you, Stephanie. I have no idea how you managed to pull that off, getting a conference from all over the world. Thank you so much. Amazing job. Guys, it's a pleasure to see you even from remote. And I'm looking forward to the day and the minute that we can all see each other from close. Thank you all so much. I think P2 is doing an amazing job. We're moving forward. And with all of your contributions, we're going to keep that momentum. Thank you all. Have a great day.